Right, I'm gonna try to be a bit quick. I know we're getting to the end of the day and you guys are probably a little bit tired. But we're gonna talk about professionalism and what we can offer you in the realm of program directors for the unprofessional resident. So first of all, the important thing to know, and this is what we tell your residents within 5 seconds of meeting them, is that professionalism is as important to graduating as medical knowledge. So you can score 100% on your in-service exam, but if you're not professional, you don't get to graduate and be a physician, okay? It's as important. It's one of the core competencies listed here, and we'll tell them that, we'll go over that, because they may say, what's the big deal? Why am I late? And we get to say, well, it is a big deal because you're here and it's a core competency. But since it's a core competency, that means it's one of the things you have to teach. And you can't really get mad at a resident for not doing something that they haven't been taught. And so how do we teach professionalism? Well, we definitely can do it through formal lectures. Highly encourage that. Informal discussions. You know, hey, I just want to let you know I saw your interaction with the patient, their family, or I read this in your note and I probably wouldn't do that. Here's another way you could do it. Just very informal. And then also, most importantly, is modeling, right? When I was a resident on my surgery rotation, the circulating nurse didn't have the right size trocar on the Mayo stand. And so the surgeon threw over the stand, he threw stuff against the wall, scrubbed out, walked out of the operating room. And I was a family medicine resident. I was like, do I go with him? What do I do? Right? And when do I obtain the level that allows me to start throwing things? Is that like a 3rd-year resident or you wait till 14? You have to model, okay? And the big push in graduate medical education is this concept of, well, this is the way I did it, so this is the way it's going to be for you. That is no more, okay? Because what we know is we did things wrong, okay? The last 100 years of medical education as we've evolved has not been great, right? I read a story about one of the great neurologists in France. He's got one of the disorders named after, maybe Duchenne. He's got some disorder named after him that we all learned about like a decade ago. And if somebody smiled while on rounds, he would grab you by your nose and drag you around the floor. Like you're not even allowed to smile. That's not what we do, right? We've evolved. So just because that's how you were taught doesn't mean that it's right, okay? We absolutely should create a nurturing, fostering environment for the residents. How do you know if you're doing your job in that regard? Is the resident comfortable coming to work today? If the resident's not comfortable because they're afraid they're going to be physically assaulted, which we've had, not like a serious assault, but like, oh, I'm sad for you. Let me grab you and walk you around the hospital. And like actually physically touching the resident who's upset, can't do that, right? But if other students or residents are seeing that, then they think that's okay. So you got to make sure the resident feels comfortable coming to work. At all times, you should be comfortable sharing your behavior in front of a peer group like this. Right? Like if there was some complaint, you know, tell us what happened. You stand up and say, yeah, you know, the resident was doing this, so I instructed them to do better. You don't want to say, well, so I forced the resident to walk arm in arm with me around the hospital while we talked about their life struggles, right? You don't want to be able to do that. So modeling is incredibly important. What do you do when a resident is not being professional? First thing is remember that it's a skill to be taught. And the good classic example is being on time. One of the residents that we've evaluated in the professionalism committee was like 20 minutes late to his night shift because he was stuck in line. He was stuck in line at Taco Bell, right? And just imagine the level of distress that's going through your mind while you're in line. I've already waited 10 minutes and it's just a short drive to the hospital. Do I wait? Do I get out of line? I get the distress, but you can't be late to your shift. You should have allowed enough time so Taco Bell is not even an issue, right? But you got to tell them that. And minor infractions represent great opportunities for you to talk to the resident and let them know that. You know, here's why it's important to be on time, and here's what's going to happen if you're not on time again. Most lapses require a professional approach. In crucial conversations, we talk about content, pattern, and relationship. Is it a one-time incident? And it's got to be a big incident to kind of, warrant professional or serious action. Most of them are like, okay, I'm going to talk to you. I'm going to talk to you again, but this time I'm going to use my serious voice. Now we're going to go to the CCC, letter of concern. It's a stepwise approach. And on the professionalism committee, we like to see that. Definitely the first time the resident's being told about the infraction should not be the professionalism committee in most cases. And those cases are never events. And this is not an all-inclusive list, but there are some things that should just never happen. And if those things happen, then we have to address them in real time, almost immediately. Number one, so it's always going to be sex, drugs, and rock and roll, right? Like you can't have sex with your patients. And in psychiatry, I laid it out very, very explicit to our interns on day one. Nothing, anywhere, ever. Don't tell me you should have got a warning. Don't tell me I didn't know it was wrong. I'm telling you all right now, any kind of sexual intimate relationship is immediate dismissal. There's absolutely no gray area for that. And that's what patients, but also remember trainees, right? That if the residents are going to be involved in medical student instruction, there should not be inappropriate boundaries with the medical students and vice versa. So just keep in mind that we also have to protect our trainees. And then drugs. And drugs fall into two categories, using and then also diverting. Okay, so using drugs, you can't show up to work high. You can't show up to work drunk. Those are big things and those need to be addressed in real time. Usually if you're to the point where you're doing that, there is a substance use disorder that's going to need some sort of intervention. But we need to address that as soon as you become aware of it. And then diverting. If you have knowledge that a resident is engaged in the illegal trade of drugs, that's a big deal. That's a big deal, and we need to address that. Now, when I sent my slides to Dr. Som, she said, what about HIPAA? I said, well, actually not. You know, HIPAA as a general rule is teachable. There are 1,000 minor HIPAA infractions as you go about the day, and you have to teach your resident about those. Like, you can't do that. You shouldn't do that. Most of the time it's ill-intentioned, right? Like I'm looking at my own chart because I didn't know I could, or my dad's getting admitted to the hospital, so I looked at the chart. And it's our job to educate the residents that they're not allowed to do that. And so I told that to Dr. Som, and she's like, well, hold on, hold my beer. Let me tell you a story. So, okay, yes, HIPAA can be a never event. And really, the cases that you hear about are celebrities. And I don't think we're getting any Hollywood actors at OSU Medical Center overnight. But like, let's say there's a high profile crime and that person's admitted to the hospital, we're all getting in the chart. You know, you can't do that. And that's pretty explicit. Getting into a partner's chart, like I'm going through a divorce, so let me find out what my wife told the therapist or the psychiatrist. You can't do that. And then other things along that. So HIPAA could be that. The other thing is violence, right? There should never be any violence among residents. And when I was in residency, I went to OU for residency, by the way. Probably gives you a lot of insight into these stories. There was the OB residents. There was some sort of discussion or argument in a C-section that culminated with one resident throwing a shoe at another resident. Seriously, who throws a shoe, right? And like, how did that happen? Like what series of events occurred that led to, but I should be able to go to work as a resident and at least expect not to have shoes thrown at me. So if we have any kind of violence, that probably would also be a never event. So those never events need to get escalated to Dr. Salm almost immediately. Serious patient or resident safety is involved, and then the professionalism committee may get involved in that quickly. What about mental illness, right? Physician burnout, physician well-being is a hot topic. Well, how does that relate to professionalism? A lot of the evaluations that we do on the committee, it's like, yeah, I know I did all that, but I wasn't mentally well at the time. And you can't really use mental illness as an excuse for patient harm, right? Because patient safety is paramount. It is number one. You can't ever knowingly put a patient in danger. And so for the residents who say, yeah, I know I put the patients in jeopardy, but I wasn't mentally ill, it's incumbent on you to recognize that. And every time you put on the white coat and step into the hospital or the clinic, wear the stethoscope, every time you enter into that relationship, you're affirming, I am mentally well enough to be at work today. Okay, and it's incumbent on the residents to say that. And one of the things we'll do in our evaluation is say that when they come to work, they are affirming on this day that I'm okay. Now, if there's any question about their ability to function mentally and come to work, then you probably need a fitness for duty evaluation. And that's a very serious kind of event. Okay, this isn't something like, oh, you know what, go to your PCP and let's see what they say. And this came up in one residency one time, and the resident came back with like a return to work note. We're not talking about that, right? It was written by like a therapist or maybe a nurse practitioner just saying, Dr. So-and-so is okay to treat patients. That's not adequate, right? Because that individual doesn't know all of the facts. They don't know what the resident does in involving patients. So it needs to be a detailed evaluation. What's going on with you? What are the facts of the concerns? What do the records show and whatnot? It can be very, very expensive, right? I do these evaluations depending on the nature of the incidents, could be thousands of dollars to get these evaluations done. Don't just tell a resident, oh, you know what, you were late 15 minutes, go get a fitness for duty evaluation. It's got to be a serious, serious thing. We do know that part of well-being has to be recognizing signs and symptoms. So in your lectures, you should be educating your residents on signs of burnout, signs of well-being, right? We remember that one of the things of mental illness is that you may not always recognize the symptoms. So you got to educate them on that. Okay. So the remediation process usually starts with the informal discussion like we talked about. You could then go to the CCC, or formal CCC action, right? Which could be like a letter of concern, we want an improvement plan. Could also be referral to the professionalism committee, or it could be probation, right? All of those different things, probably among others. So what I'm going to talk about is the professionalism committee. We have two teams that include me and Dr. Farrar, and I don't think she's still here. Dr. Gill, you raise your hand. And Dr. Thurman. Both Dr. Gill and I are forensic psychiatrists, so we do these types of evaluations for workness, for fitness for duty for any kind of workplace, but also for medical boards and other professional licensing agencies. So we've created the teams so that they allow there to be a forensic psychiatrist, not only on each team to be able to really look through the facts and synthesize it, but also it leaves one of us open to work with the medical board if necessary, which often is. Many of your residents that are being referred to us are also being referred to me by the medical board for different issues, or they will be. So when do you refer to the professionalism committee? Well, definitely multiple lapses, right? Like they're just not getting it. We've talked to them and we've talked to them, we've talked to them. but they show up 15 minutes late with the Taco Bell sack every single night. One serious lapse, and we get a lot of those, right? Like really big thing. One of the last things we got, I think, was a ER resident in a very critical, serious code type situation, wouldn't let the attending take over, right? And you can't do that, right? Like if the attending shows up and says, hey, I need to do this, you got to let them do it. Or insight or defensiveness. And I think I heard this in the last or one of the previous lectures is, what do you do for that resident who just doesn't think that they've done anything wrong? Send them to us. And we will educate them on why they've done it wrong. We'll document that education. And at the end of the day, I'll say it doesn't necessarily matter what you believe. This is what the committee believes. And you have to come to our kind of understanding, or you're not going to meet the milestone. And you're not meeting the milestones now. If you don't fix this, you're not going to graduate, right? So a lot of residents don't understand that there's not a requirement that they graduate once they've been accepted, right? And that they get yearly contracts, and we'll tell them, and we'll say that your contract is dependent on meeting the milestones. Right now, you are not meeting those milestones. Also, you might want to send to us for a second opinion pending serious action. If you're going to terminate a resident and it's tricky, you really got to get all your ducks in a row. And you may want just a second set of eyes, make sure it's not all on you, that you're, that this is as egregious as you think it is, this is non-remediatable or whatnot, and you'll send it to us. But that comes with the caveat. All right? You got to use it with caution, because it could help support you in litigation. If there's a lawsuit, then now Dr. Beaman's got to get up there and say why he also agrees with that. So it helps kind of support that it wasn't just you, and it splits the decision making. However, just because you send them to us, we're under no obligation to agree with you, right? And if you send them to us and we give recommendations and you avoid those recommendations, and then there's legal action, now you're having to answer why. Well, didn't the professionalism committee say this and you didn't follow that advice? And so you got to be careful. I highly, highly recommend you follow through with our recommendations if you send someone to us. Okay, when you send someone to us, you have to provide a detailed description of the lapse. And it's got to have specific details. I'm essentially going to be in an argument with this resident. I got to be armed with the facts, right? Because they're going to say, no, I wasn't late. Well, I don't know why the program director is saying they were late. So you can't tell me that they're argumentative or late, because those are vague, and I can't argue that. A good referral is they were late on this date. They were supposed to be here at 0700, didn't get here until 7:30. The resident was educated on the appropriate time limits on this date, and this date. And then when I talked to them, they said this or whatnot. Those are very specific facts, and we need those, because now I'm going to tell the resident, well, your program director says that you were late on this day. Is that true? Yes, right? So we have to establish the common facts first, and I don't want to spend the entire evaluation on arguing over whether or not they were late when I don't have the evidence. I will tell you, Dr. Som will not let you refer to us without a very adequate referral. And if you've tried it, you'll understand what I'm talking about, right? She'll say, no, this isn't adequate enough. Come back with more information. Dr. Som previously served on the professionalism committee, so she knows what we need and what we're looking for. When you refer the resident to us, we're going to go through, first of all, an investigation, and it's not an extensive investigation. We're probably not going to interview other residents or whatnot. We're going to talk to the necessary faculty. We'll talk to the resident and use the resident side of the story as part of our investigation. We'll talk to the resident, we'll look at all the facts, and we'll give a summary letter to the program director and to the DIO. All right, when we talk to the residents, it's both investigative and educational or therapeutic, right? It'll give us an opportunity to tell the resident how serious things are. By the time you're sitting in front of me, this is bad, right? This is serious. You're looking at potential termination. We want to get the residents' version of event. And a lot of times we've heard things that, sound really, really bad when we get the referral. And then we talk to the resident and it turns out that's not so bad. Also, we'll talk to the resident and they will come in and say immediately, look, I messed up. I didn't understand what I was saying. I didn't mean to say that. I messed up. I'm never going to do it again. We like to see them, right? Good insight. They recognize it. Probably not going to happen again. We will challenge all discrepancies. And that's kind of what we do is beforehand, we'll pull out all the facts and I'll say, tell me about this. Tell me about that. No, that didn't happen. Well, your program director told me it happened and you're saying it didn't happen. Help me understand those two things. But I need to resolve that discrepancy. Either you're lying or the program director is lying, but you need to tell me which one you think it is. Well, I didn't say they were lying. And actually, maybe I was, maybe they thought I was late. Okay, so we'll tease through all of that, but all discrepancies will be resolved. And we'll use the conversation as an opportunity to reinforce professionalism. At the end of that, we're going to give you a summary letter. And this letter carries the full weight and authority of the committee. I will stand by everything I put on the letter, right? I won't back away from it or wash away from it or anything like that. If I write it down, then it comes with the full weight and authority of the committee. We'll summarize the residents' remarks and thoughts regarding the lapses. Usually I'll tell you kind of key words like resident so-and-so did not agree with any of the comments by the program director. Also, whatever you send to me, I'm going to share with the resident. So just be mindful of that. If you say they were late, just know I'm going to tell the resident you said they were late. If you say that they were not responsive to feedback, I'm going to tell the resident they were non-responsive to feedback. Hypothetically, you should have reviewed all of those incidents with the resident prior to coming to us. So there shouldn't be any surprises. I'll tell you that they immediately were apologetic. They recognized their lapses or they didn't. And then it'll contain recommendations. The recommendations are, a lot. We have a lot of things. The most common thing we do is recommend Crucial Conversations. Crucial Conversations is a certification course that is 16 hours. Dr. Sam and I, we're trying to put that into 8 hours. And then your residents will be certified in Crucial Conversations. I know a lot of you are. We also offer it for faculty at time to time. But it basically teaches us how to talk to each other. Most of the referrals that we get are because we're not talking to each other in the right manner. And so Crucial Conversations will tell the residents that. We will offer that to every single resident prior to starting. And so a lot of times they've already had that and we use that model during our discussion. Zero tolerance for future lapses. Okay, I get that you didn't realize how serious being late was, but now you do. So now there's a zero tolerance for anything. You have to prove to us that you have gotten it and that it's not going to happen again. May actually have the resident present on professionalism. Okay. Not only do you have to understand it, but you got to write a lecture on it and deliver it to your residency. And I'm going to sit in on that lecture just to make sure that it's adequate. And then we may do a very tailored approach to that specific resident, right? Here's the lapse and here's what we're going to do. A lot of times, the thing that's needed the most is an apology, and we're never going to mandate someone apologize because that's kind of a ridiculous thing to do, right? My aunt used to tell me if you were sorry, you wouldn't have done it in the first place. So we need the resident to recognize that they did something wrong and that an apology is helpful. And I may guide them there, but we'll never mandate it. So you know that if you get a resident apologizing after one of our evaluations, that they're doing that on their own because they think that that's an important thing to do. One of the things I want to discuss is the concept of light duty. Okay, well, you know what? They're going through some things, so we want to put them on light duty. And you know what? For the rest of the residency, everybody else has to work, see 12 patients in a half day, but this resident's only going to see 3 for the rest of their residency. I highly, highly encourage you not to do that. Okay? Now, at times you can modify for short-term periods, you can modify work duties, but remember that when they graduate, you are saying that they met the requirements to practice as a full physician, right? That they can go to Warren Clinic and see like 36 patients a day, not 3, right? And there's absolutely liability in the residency not providing the adequate training for the resident to then go out and they hurt people, right? I'd refer you to Dr. Death if you listen to that podcast. University of Memphis took a lot of heat for graduating that resident, even though he didn't actually do the residency, right? So absolutely inappropriate to do a lighter residency. Like residency is residency. You've all put in a lot of work to create a standard residency for your entire complement. Not like, well, if you have depression, you're going to do this residency. If you have anxiety, you're going to do this one, right? All of our residents complete our curriculum. And if they can't complete the curriculum, should they graduate as a resident? There's all sorts of mechanisms, leave of absence and disability and all that to address those people that can't handle the workload. We should not necessarily modify it for long periods of time. Perfectly okay to do short-term stuff, but remember they have to complete the requirements of the residency. At the end of the day, the resident is either fit to come to work or they're not. And you can't say they're kind of fit because it's patient care, right? It's patient care. They're either fit or they're not fit. Again, fitness for duty. This is a specialized evaluation that includes a review of all known information. My evaluation with someone for fitness for duty will be 2 to 6 hours long. Okay, this is not a 30-minute come tell me how you're doing today. This is an extensive evaluation that goes through their entire life trajectory. It's a comprehensive evaluation that includes review of all of the records. So I can't get a report to you tomorrow. Usually it's about 30 days because I'm waiting for records to come in and I need to know what those records say. And at the end of the day, it's going to be an expert opinion that I would be willing to go to court and justify. Like if I say this resident isn't fit for duty and they sue, then that can end up in court and you need somebody to be able to go up there and say why or why not. So what we've been working with Dr. Som on is evaluators that we agree with that aren't just going to rubber stamp something, but will do a good job. We're not trying to tell the evaluators what opinion to come to. We're trying to tell them the mechanism to use to come to that opinion. There are some other avenues to let you know about. Remember that residents are able to go to the Oklahoma Health Professionals Program, OHPP. They can be referred or they can actually kind of self-report and go voluntarily. OHPP allows a mechanism for mental health and substance use to be addressed alongside the board, okay? Not outside the board, but alongside it. And basically the medical boards have said, you know what, if you participate in OHPP, then we're gonna let them handle it and we're not gonna take action on you as long as you're complying with their demands. So failure to adhere to that though, then OHPP will say, well, we're gonna send you to the board. And if it comes to the board from OHPP, it's probably not going to be good for the resident, right? So it's a really good way for them to get help in treatment without losing their license or their ability to practice, but they're going to be probably doing like urine drug screens every day, once a week. They can't have drugs or alcohol, all these other things, and they're monitored very, very, very closely. All right, questions? Any questions at all about professionalism? Not everybody at once. Questions? All right. Thank you, Dr. Tom.